Bismillahirrahmanirrahim. Assalamu alaikum. Professor Aisha Humayun here. Today, this video is about clinical audit from concept to execution. So in this video, I'll be sharing the concept of clinical audit, how it is conducted, steps involved, and I will be sharing few examples with you. And I will be sharing a template as well, and the difference between clinical audit and quality improvement project and RCT, what are the key differences and how you can change a clinical audit into a quality improvement project, and all these important aspects we'll be discussing today. So what is clinical audit? It is a systematic review of care against defined standards. It identifies gaps in compliance with evidence-based practices, and it is also used to improve patient care outcomes. So evidence-based practices or the standards, uh, they are defined, and we need to check our practices against those standards, whether there are gaps or there are issues in compliance, and in that way we can bridge those gaps. So ultimately, the purpose of clinical audit is to improve patient care outcomes. Now, the steps in clinical audit. It starts from selection of a relevant topic and then defining the standard and criteria against which we are going to measure the care, then collect the data, compare with the standards, implement the changes, re-audit to evaluate the impact. So in audit, we are assessing and then implementing the change, whatever change or intervention we are planning, and then we re-evaluate the impact of that change. Okay, so here I'm giving the example of my own hospital, Sheikh Zayed Hospital in Lahore. Um, three audits were conducted in recent past. One was audit of compliance with hand hygiene protocols in surgical ward. The second one is audit of timely antibiotic prophylaxis in elective C-section, and audit of documentation standards in patient discharge summaries. So, these are a few common examples. Uh, Now, what is the difference between a clinical audit and a QI project? Clinical audit, it measures compliance with established standards, and in this we ask, are we doing it right? The question is, are we doing it right or not? Because we know the right is the standard, and we are checking whether we are doing right or not. And in QI, we focus on processes, uh, improving the processes, process improvement, and testing the change. If we improve the process, what will be the effect? How much change will be there? So QI project is focused on improvement and change. A QI question that we ask, how can we do it better? And in that way, it differs from the audit, because how can we do it better and are we doing it right? There is a difference, because this is against, we are measuring against standard, and in this case we are not measuring against standard. And for a successful QI project or an audit, we should start with small, one board or a process or a service, and then you can use team-based approach with frontline staff, and in that way we will get a maximum benefit of that. Collect minimal relevant data, close the loop, implement, reassesses, and sustain the change. So by closing the loop, we mean we need to implement the change, reassess whether now we are meeting the standards or not, and then sustain the change, continue with that practice. Then the fifth one is celebrate small wins and share your learning experience with other wards and other departments. In that way, you can promote a culture of clinical audit and improvement. So, difference between a clinical audit and RCT. In clinical audit, we assess compliance with existing standard. The design is observational, retrospective, or prospective data is collected. Data collection is in a real world practice versus the guidelines. The comparison is in the real world practice and the guidelines. So the data is collected from the real world. while in the ethics approval is often waived off because the patient data or the data you're using, that is kept anonymized. Example is, are antibiotics given on time in C-sections? So this can be an example of clinical audit question. In RCT, we test efficacy of new interventions. Experimental design is used, random allocation of groups, and comparative outcomes are there. We are comparing drug A with the drug B or with the placebo. So it is always ethical approval is required in RCT because informed consent is needed. And the question driving the RCT is, does drug X reduces um, SSI better than drug Y? So does drug X maybe any drug that we are going to check whether it reduces the surgical site infection better than the drug Y. But in this case, we are checking are antibiotics given on time in C-section or not. So there is a difference in the question driving that activity, maybe a clinical audit or an RCT. Here, RCT can trigger QI. Poor audit results may lead to a QI project. For example, you did a clinical audit and the result was poor compliance of patients with the standard. In that case, you can ensure you can start or trigger a QI project, trailing a new workflow or conducting some trainings and then looking into the effect of that training. QI can inform audits. Yes, successful QI outcomes, for example, checklist adoption. You developed a checklist, and that checklist was adopted by the ward or a service. That is an example of successful QI outcome, and it may become a new audit standard. That new checklist can be an audit standard, so you can compare your practices with that standard. Audit is a snapshot of compliance, while QI is a dynamic process to innovate. Together, audits identify the gaps while QI closes them. So they go hand in hand. If you are running an audit, that ultimately can trigger a QI, and a QI is a dynamic process that innovates and closes the loop, while audit identifies the gaps. So audit finds out only 60% of C-sections meet antibiotic timing, if this is the example. QI project test a nurse-led pre-op timeout. Compliance rises to 95%. So in QI, you are testing an intervention, while in audit, you are identifying a problem, you are assessing a problem, meeting whether the standards are being met or not. And here you are actually improving the standard by using this intervention. So new audit monitors sustained improvement. A new audit can be conducted to monitor sustained improvement. Okay. Now, the key differences between QI project and clinical audit in a detailed way. But the primary goal of clinical audit is to check compliance with the existing standard, while QI project improve processes or outcomes beyond current standard. Focus is of CA is, are we doing what we should, following, for example, following the guideline? And in QI, how can we do this better? For example, some innovative workflows. While the design in this case is retrospective or prospective observation, while QI projects, they are interventional. They test changes via PDSA cycle that we already have discussed, plan, do, then study and action. Data use, it measures adherence. For example, 70% compliance. It will tell you there is 70% compliance to any procedure or any step. So while QI tries new methods, measures the impact. For example, reduced errors by 30%. So instead, while comparing the standards, clinical audit compares to fixed criteria, for example, WHO standard or a standard of a guideline by a Royal College or any other international guidelines. So while QI may create new standards through iterative testing. So these are few key differences between CA and QI. Steps in conducting a clinical audit. You select the audit topic. For example, taking the same topic, are antibiotics administered within 60 minutes before skin incision in elective C-sections as per WHO guidelines? Define the standard is the second step. The standard is WHO and ACOG guidelines. Antibiotics should be given within 60 minutes before incision. This is the guideline. Okay. Then exclusion criteria, emergencies and maternal allergies to antibiotic. They will be excluded. Data collection, the method will be the retrospective review of 50 elective C-section records. Random sampling will be done, and the check in the records will be the time of antibiotic administration, the type and dose of antibiotic, compliance rate with guidelines. So these three things can be noted down from the files. And now fourth step is to analyze the findings. Example result are 70% compliance, 35 over 50 cases met the 60-minute window. And reason for non-compliance, delayed anesthesia could be a reason that we can dig into. That is 20% were because of delayed anesthesia and 10% were documentation errors. Fifth step is implement improvements action plan. And education, first point is to educate, train staff on timing importance. Checklist, anesthesia team confirms antibiotic timing, and this can be ensured by training the anesthesia team on the checklist. Then electronic alerts, reminders in emergency room or where they can have the alarm system or electronic alert that the antibiotic must be given. Re-audit after 3 months can be conducted to compare pre versus post-intervention compliance. The goal is more than 90% adherence. Okay. The AI tools for data extraction and analysis, we have certain tools available. They can help in data collection, data extraction. For example, Deep Note, Monkey Learn, Google Vertex AI. These are few tools. These are AI assisted coding of audit statistics. And here we can extract antibiotic timing from EHR notes. And Google Vertex AI identifies SSI risk factors post audit. So this is for the predictive modeling. We have certain platforms which are AI powered for the clinical audit. Deduce is a real-time compliance tracking, flags missed antibiotic pre-op, and Quantus surgical pathway audits is being done through Quantus, predicts delays in antibiotic administration, and IBM Watson Health, that is benchmarking against guideline, compare hospital data to WHO ECOG standards. So these are certain platforms that we need to know. They can assist us in conducting clinical audits. So this is a checklist of the clinical audit. These are the steps actually mentioned in this in the form of a checklist. The planning phase, define audit question and scope, identify stakeholders like Ob-Gynae department and anesthesia department in this case, standards, review guidelines, and set measurable criteria. Data collection, obtain ethical approval if needed. If there are names, then you need to then collect sample records, for example, 50 cases. Analysis, calculate compliance rate, identify root causes of non-compliance. Improvement, present findings to the team, implement changes through training or checklist introduction. And in this way, you are improving that audit based on the audit report, you are improving. Then the re-audit, repeat audit post-intervention, compare results and document progress. So in that way, this is the, we are completing, or this is the clinical audit cycle, and actually we are completing the loop. So now example of a clinical audit, this is the template that I'm going to show you, the title of the topic on which you are conducting clinical audit, then the subtitle, then the audit lead, the date, and then you can write the executive summary, telling the objectives, sample, the findings, recommendations, and you can give the background, like why it matters. SSI occurs at 5 to 15% of C-sections according to WHO in 2023. So timely antibiotics are very important. They can reduce the SSI risk by 50%. This is again a study a reference. So audit question, you write after the background, are antibiotics administered within 60 minutes before incident or not? So this based on this question, you make your methodology, the standards, sample size, data sources, exclusions, and then you document the results, 70% adherence and 30% non-adherent. You can present it like in form of pie chart, or you can give a benchmark comparison, and root cause analysis can also be conducted. You can show anesthesia delays as because anesthesia delays we assumed they were 20%. So largest bar will be of anesthesia delay in root cause analysis. Part I have given the detail of root cause analysis in my quality improvement video, QI video. I will be sharing the link in the comment. You can go there and see how the root cause analysis can be conducted. What are the different options? So here I'm just giving you the name. Anesthesia delays can be shown in the form of bar, and documentation errors, pharmacy delays, and here you can identify the systemic versus human factors in pharmacy delays, and you can use bar graph to express your findings. Intervention, the team was staff training of OB-GYN team in the month 1. Pre-op checklist will be introduced by the nursing team and will be filled by the nursing team in the first month, and AHR alert system will be introduced in through the IT department, IT team, and this will be introduced in the second month. Then re-audit will be conducted after 4 months. The quality team will be conducting the re-audit. So the intervention team and timelines can be shown in the action plan. So the conclusion and next steps. Number 1, the goal is to increase compliance to 85% by third quarter of 2024. This can be time bound. Then re-audit plan, track post-intervention data, and that will be our re-audit. And the call to action is to collaborate to reduce SSI. This is the next step. These are the references. At the end of the clinical audit report, you should present your references as well. How to run a 5-minute infection control audit. This is just a flow chart showing for infection control that is a very simplest clinical audit that can be conducted. Pick one patient care zone, hallways, nursing station, or med pass areas work best for quick wins. And observe 3 frontline interactions. Watch how PPE, hand hygiene, and cleaning protocols are actually followed. Okay, and ask this question: who owns this space? If no one can answer this, that's a risk. Assign clear responsibility. Check logs versus real life behavior. Are clean logs filled? Great, but did cleaning actually happen? That is again a big question. You are comparing the logs with the real life behavior. Note one fix and share it on the spot. Close the loop. Fast coaching in real time builds accountability. So that is a very small, short example how you can conduct clinical audit, other than the example that I have already shared with you about the C-section. Okay, so there are ethical principles applied on clinical audits as well. And these are patient confidentiality, re-identify data, like we have to follow HIPAA and GDPR guidelines, and we have to be compliant to that. And informed consent required if audit impacts the care. For example, UK NHS HREC approval, they are required. They want that informed consent be taken. And bias mitigation, use blinded auditors, disclose conflicts of interest. Transparency, publish negative findings as well, along with the positive findings. There are BMJ opens audit reports available. There's a place to publish. And ethical frameworks, there are many other options as well other than BMJ. Then ethical frameworks need to be followed, and the Declaration of Helsinki, patient welfare first, is need to be followed as a principle. And GCP audit guidelines, they are also there, and they are also to ensure for data integrity. And the common pitfalls that we see are data cherry picking, report all metrics, not just favorable one. So this is very important, where we can create a bias and we can neglect the certain data by data cherry picking. So another thing is unauthorized data use must be prohibited. Obtain IRB approval even for retrospective audits. So it's preferred that you ask for IRB approval, and you go for informed consent as well. So these two things are important in clinical audits. This is a template. On one slide, you can see the title of audit, department, audit lead, date of audit, background, rationale, aim, objective, standard criteria, methodology, and results, analysis, recommendation, action plan, and re-audit date. So action plan is actually after the audit, there must be an action plan, there must be a re-audit date, then the audit loop will be completed. So this audit triggers the action plan and the audit. Conclusion, both audit and QI are essential for quality clinical governance. So when we talk about clinical governance, QI and CA, clinical audit, they both are very important. They both are the tool for clinical governance. They support safer, more efficient, and patient-centered care. Embedding these practices builds a culture of continuous improvement. So when we talk about clinical care, we should talk about quality of clinical care. And quality means you should have a practice of clinical audit and quality improvement projects. So thank you very much. You can ask question in the comment box. Please like and subscribe my channel.